Okay, fine. So in today's session, I have kept a few MCQs from NEET-PG, and this is actually for students who are aiming for 11th August the NEET-PG exam, right? So like anyone can join it. That's not a problem at all. But this has been prepared especially for the students who are aiming for a NEET-PG exam, right? So the very first question was like. A patient who has been diagnosed as Duke-Irwin's tenosynovitis, and it has been asked like it involves which two muscles tendon, right? So students were supposed to answer like which the tendon of which muscles are involved. Now to answer this question, you have to go a little bit in anatomy of the anatomical snuff box, right? So you have to go in the anatomy of the little bit in the anatomy of this anatomical snuff box, and you know that it has two borders. One is medial and another is lateral. The medial is formed by the extensor pollicis longus, and the lateral is formed by two muscles. Okay, it is formed by two muscles. One is abductor pollicis longus and second is extensor pollicis brevis, right? रमन भाई नमस्कार. बाबा बैरागी आप बिल्कुल परेशान मत हो बच्चे, आप मेरे को मेरे नंबर पे एक बार मैसेज कर लेना या फ़ोन कर लेना, फिर हम 1-to-1 बात करेंगे, राइट? तो आप परेशान मत हो बिल्कुल, ठीक है, डोंट वरी. आप मेरे को पर्सनल नंबर पे मैसेज ड्रॉप करो, मैं आपसे बात करूँगा कल, ठीक है? सो एनीवे, कमिंग बैक टू द सेशन. सो this is the anatomy of the anatomical snuff box, and the tendons which forms the lateral boundary of the anatomical snuff box are actually involved in Duke-Irwin tenosynovitis. So if you know that what are those two tendons, one is abductor pollicis longus and second is extensor pollicis brevis. So therefore your answer will come out to be abductor pollicis longus and extensor pollicis brevis, right? So pollicis, the word pollicis actually means thumb, abduction and extension, of course. Now in this image I have tried to show you the Finkelstein's test, which we do for Duke-Irwin tenosynovitis, right? So what actually we do, we try to give some traction to the tendons which are already inflamed, so that tractional movement will cause pain. So what we do, we just put the thumb like this, okay? So we make a fist and we suddenly ulnar flex it, right? So that will cause stretching of the tendons of the extensor pollicis brevis and abductor pollicis longus. So this is the Finkelstein's test or Finkelstein's maneuver, which is done for Duke-Irwin tenosynovitis, right? So you can see the thumb is clenched between the fingers, and then we give a sudden jerk, ulnar flexion kind of jerk at the wrist. So this will cause severe pain over the site of inflamed tendons. So this is Duke-Irwin tenosynovitis involving the abductor pollicis longus and extensor pollicis brevis, and this is the Finkelstein's test which is done clinically to diagnose the Duke-Irwin tenosynovitis, right? Chalo, now let us move to the next question, and here a young lady, right, is having pain and she's having pain in small joints of the hand, and there is morning stiffness, right? And then the hands are having deformities as well. Now very good KK, very good. The moment you find this particular word, young female, involvement of hands with morning stiffness, straight away you can go to the diagnosis of rheumatoid arthritis. Right? So this is a very classical description. Yes, Raman bhai, this is rheumatoid arthritis. Okay? Rheumatoid arthritis. So this is a classical description of rheumatoid arthritis, and there are few more important terms. Pragati Rai, absolutely you are right. This is rheumatoid arthritis, and there are few more terms which you should remember apart from these, like the points which are like which help us in making a clinical diagnosis of rheumatoid is young female, of course, right? Then pain, swelling over hand, right? And sometimes you might have find a word symmetrical. So the deformities in the right hand are similar to the deformities in the left hand, and therefore we use the word symmetrical. And classically it involves which joint? MCP joint. This is classically involved. Clear? And if you can look in the image, this is the area of MCP joint, and you can see there is bogey swelling also. You can see the bogey swelling here, right? So this is the classical MCP joint involvement in rheumatoid arthritis. Okay, this is one thing. Then morning stiffness. This is again very important. Morning stiffness, and if the disease has progressed too much, you might find deformities. It can be ulnar deviation, right? And it can be swan neck. Like if you see here, you can see the swan neck deformity. Clear? So a classical swan neck deformity in which there is hyperextension at PIP, right? So this is the PIP joint, proximal interphalangeal, and there is hyperflexion at DIP, the distal interphalangeal joint, right? So this is the classical swan neck deformity. You can have boutonniere deformity also, which is just opposite to this, and you can have ulnar deviation as well. So this is a classical description for rheumatoid arthritis. So the moment you have these keywords, straight away you can go to mark rheumatoid arthritis. Now I have kept one more question so as to discuss this concept a little bit more. So there is an elderly lady. Now look here, there is elderly lady, and the involvement is of DIP, PIP, first carpometacarpal, right, related to thumb, and there is sparing of wrist and the MCP joint. Now what will be your diagnosis? So what if I just mention the points here? Elderly female, number one, right? So very good, KK, very good. Second is sparing of MCP, right? And third is DIP plus PIP involvement. Now the moment you have these 3 points, it cannot be rheumatoid arthritis, right? Pragati Rai, very good. This is osteoarthritis. Now when you have these 3 points, never think of rheumatoid arthritis, because we have already discussed in, suppose if on this side I am putting rheumatoid, and yes, everyone is correctly diagnosing it. This is a case of osteoarthritis of hand. Now what points you will see here? Young female, right? So whatever the age is given in the question, it holds a lot of importance. If it is young, think towards rheumatoid. If she is elderly, think towards osteoarthritis, right? Number one. Number two, MCP is the most common joint involved in rheumatoid arthritis, where it is not involved at all in osteoarthritis. So this is one important difference. Third, in rheumatoid, there can be involvement of proximal interphalangeal joint, but never distal interphalangeal joint. But in case of osteoarthritis, you are seeing that both the joints are involved. right? So these are three important points which you have to search out in the clinical history before marking your answer. So it's quite easy. The only thing that you have to be very vigilant while reading the question, right? So just look for these 3 points and you'll be absolutely right in making a diagnosis. In this case, it is, of course, this is osteoarthritis. Clear? So this is osteoarthritis. Now I have kept an image just to discuss little bit of differences between the osteoarthritis of hand and the rheumatoid arthritis. Now we call it osteoarthritis, but actually it is not an inflammatory pathology. So in real terms, this is misnomer, right? Because we know that whenever there is word itis, it means inflammation, but in osteoarthritis there is no inflammation as such. It is only the degeneration of the hyaline articular cartilage, and we call it usually the normal wear and tear with age, especially in primary osteoarthritis, right? So this is a degenerative disease and not an inflammatory condition what we see in a patient of rheumatoid arthritis. So rheumatoid arthritis is inflammatory autoimmune condition, and osteoarthritis is a degenerative condition, and that is the wear and tear of the hyaline cartilage. Number one. Then the morning stiffness is more indicative of rheumatoid arthritis as it lasts for more than 30 minutes. But there might be morning stiffness, but that is not long lasting, right? So morning stiffness has to be taken more in favor of rheumatoid arthritis. Then I told you that DIP is not involved in rheumatoid arthritis. So here DIP not involved. Clear? But distal interphalangeal joint, this one, it is involved in osteoarthritis. And what we see here, we see Heberden's nodes, right? So these Heberden's nodes are present in distal interphalangeal joint, right? There are Bouchard's nodes also which are present in proximal interphalangeal joint. So here we can see the Bouchard's node. Clear? So these Bouchards are in proximal interphalangeal joint, right? So what I mean to say that there is involvement of DIP in osteoarthritis but not in rheumatoid arthritis. Then another important word, what I told you about rheumatoid arthritis is symmetrical. There might be same deformity in the right hand and in the left hand, and it looks somewhat like mirror image. So symmetrical is the word which has to be remembered for rheumatoid arthritis, and needless to say, the changes are asymmetrical in osteoarthritis, right? So, and apart from that, in rheumatoid, we can see extra articular involvement. It means there may be involvement of different organ systems apart from joints. So this is in short the basic difference between the osteoarthritis and rheumatoid arthritis, and this will definitely help you reach up to the perfect diagnosis of the question, right? So anyway, now next question. Elderly patient has low back pain, right? So he developed sudden low back pain, and when you took X-ray, this was the X-ray, right? So here number one is elderly patient, right? Then sudden low back pain. And when you look at the X-ray, I think yes, KK, you are absolutely right. You can classically you can see codfish mouth vertebra, right? So this is okay. So this is codfish mouth vertebra. Clear? So classical X-ray of, yes, Pragati, you are absolutely right. Caught fish, yes, right. So what you can see actually, the vertebral bodies, they are so much weak that this disc actually pushes the end plates inside, right? So it's actually pushing this thing inside, and therefore we have these biconcave vertebrae, right? So this is a classical case of osteoporosis, right? So you have cod fish mouth vertebrae on X-ray. Clear? So the moment you have these kind of hints, I think everyone can mark it absolutely right. So this is osteoporosis. Then next question was about scoliosis, and it was about identifying what measurement is being done over here. So the case is scoliosis, right? And you can see the curvature in the vertebral column, right? So this is scoliosis. Any idea what angle do we measure in scoliosis? Any idea? What angle is this which is being measured here? What is this? Anyone? KK, not Adam's apple. This is Cobb's angle, right? Clear? So this is Cobb's angle between the primary and the secondary curvature of the vertebral column in a case of scoliosis, right? So this is Cobb's angle, and it's just a numerical measurement about the curvatures or the deformity between the primary and the secondary curvature of scoliosis, right? So this is Cobb's angle. So just remember the name, Cobb's angle, right, for scoliosis. Okay, chalo, no problem. Now, a patient was having rupture of long head of biceps tendon. Now, which clinical sign is this? I think everyone can answer this. This tear or rupture of long head of biceps. This gives which sign? Popeye sign. Very good. So this is actually related to one, yes, Pragati, absolutely right. So this is related to one cartoon character, one sailor who have this kind of prominent biceps. So this is something like this, and this is because of the tear of the long head of biceps, right? So if I draw, this is the supraglenoid tubercle, and from here this is the long head of biceps. So this is originating from supraglenoid tubercle, right? And then, as the name suggests, biceps, so there is one small head also. So this is the small head of biceps, and small head of biceps is originating from coracoid process, right? So these are the two heads of biceps brachii, and whenever there is rupture or tear of the long head of biceps tendon, the muscle belly, it just rolls downward and it forms a lump which looks like the muscles of Popeye, the cartoon character, right? So this is known as Popeye's sign. So nothing more to discuss here. Now next question, a patient was having, again, if you can just notice the age, it is also very important. So young patient having knee pain with swelling, and when we did biopsy, we found multinucleated giant cells and mononuclear cells. Now the moment you have this kind of histological picture, I think that's very clear to make a clinical diagnosis of, yes, anyone? Multinucleated giant cells, mononuclear cells, swelling and pain around knee joint in a young patient. What is, yes, KK, perfect. So this is giant cell tumor, which is also known as osteoclastoma, right? So now the word is multinucleated giant cells. So there is a big cell and it has got many nuclei, right? So this is known as a multinucleated giant cell. And on the other hand, there are some more cells which are actually having a single nucleus. So these are the mononuclear cells. Mono means single, multi means many, right? So these are the two cells which we will see in the histology of giant cell tumor. And in older times, it was previously, these were presumed to be the cancerous cells, okay? Clear? And therefore, this was the nomenclature based on that histological picture. So they thought that these multinucleated giant cells are the tumor cells, and therefore they gave this term giant cell tumor, and it was presumed that they might be having some osteoclast-like activity, so they called it osteoclastoma. But later on, it was realized that these were not the tumor cells, these are the real or actual tumor cells. Clear? So if someone asks you which are the tumor cells of the giant cell tumor, then your answer would be the mononuclear cells and not the multinucleated giant cells. So this term actually is a misnomer. It was coined based on a wrong perception that these multinucleated giant cells are the tumor cells, but that is not the case. So if you look a proper histological slide, you can see these are all multinucleated giant cells, okay? So you can see here, this is a cell here, and you can see all nuclei within that, right? So these are all multinucleated giant cells. Multinucleated giant cells, right? And whatever the small cells you are seeing in between, these are mononuclear cells. Cells having a single nucleus, right? So this is a classical histopathological slide of GCT or osteoclastoma, and I think no one should err in this. You are not supposed to commit any sort of mistake in this. This is a very basic thing and commonly asked, right? Chalo, next question. Child, 2.5 years child, was lifted by her maid holding the wrist of the child, and then this child started crying and does not allow anyone to touch his upper limb, or neither he was moving his elbow joint, and he was crying in pain. So what is this? So if you look, holding a child by the wrist, something like this. So any idea what condition is this? A child lifted by the wrist and then suddenly started crying and is not moving his elbow joint. What condition is this? Anyone? Very good, KK, very good. So this is known as pulled elbow, and also known as nursemaid's elbow, right? Yes, Pragati, pulled elbow. KK, absolutely right. This is pulled elbow. And now what happens in pulled elbow actually? Suppose this is upper part of ulna, right? So suppose this is upper part of ulna, and then surrounding it is the head of radius, something like this, okay? So this is the radial head. Now this radial head is surrounded by an annular ligament, right? So there is an annular ligament which is holding the, so this is the annular ligament. So this annular ligament is holding the head of radius in relation to the proximal ulna, right? Yes, Pragati, now nursemaid's perfect. Now what happens when a child is lifted by wrist? So this head of radius can just slip out of this annular ligament, and then the condition is extremely painful. The patient will not allow anyone to touch his elbow, neither he will move his elbow. So this is nursemaid elbow or pulled elbow. So if we look here, this is the annular ligament, right? So this is the annular ligament here, and the head of radius, it just comes out of this annular ligament. So now what we need to do, so usually the child will come in this kind of position, so simply supinate it and just flex it, right? So supination followed by flexion, that will reduce the head of radius back into the annular ligament, and that will cure the condition as such. So this is the treatment. Supinate and flex the elbow, right? So this is in short about nursemaid elbow, or also known as pulled elbow, and this is the usual cause if a child is lifted off the ground holding both the or the single upper limb through the wrist, right? So this is pulled elbow. Chalo, next question. A patient with road traffic accident and is having respiratory distress, and look at the time, 72 hours after the injury. PaO2 is less, which is not responding to oxygen therapy, and there are neurological symptoms as well, and he was having multiple injuries. Now what will be, yes, KK, absolutely right, absolutely right. So this is a classical case of fat embolism, right? So what points you need, yes, Pragati, absolutely right, this is fat embolism. So what you need to remember, number one, there is multiple injuries, right? And sometimes in the question they can specifically give you fracture femur, that might be mentioned because that is the usual place from where the fat globules from the marrow of the femur, they get entry into the circulation, and then they can move to distant places, right? Then there would be respiratory symptoms. Clear? So there would be respiratory symptoms. Then there would be CNS symptoms, and fourth and most importantly, you can see rashes also, right? And this all in setting of road traffic accident, and usually the time period is taken as 48 to 72 hours, right? So the moment you have this kind of picture, straight away you can go on to fat embolism, right? There can be changes in eye as well, but these are the classical points which are mentioned in the case history most of the time. So multiple injuries involving including fracture shaft of femur, then respiratory, CNS, rashes, and typically 48 to 72 hours after the injury, right? Now this is actually a anatomy based question, but it was there, so I just kept it. So you have to identify what type of cartilage is this. So we have three type of cartilage: hyaline cartilage, then the second is fibrocartilage, and the third one is the elastic cartilage, right? So yes, KK, you are absolutely right, this is elastic cartilage. And just we can just take a few examples. Hyaline articular ends, or the growth plate, fine. So we'll just take the important ones, which, yes, Pragati, absolutely right. Fibrocartilage, intervertebral disc, or pubic symphysis. I'm just mentioning the important ones, right? And the elastic cartilage, you can remember pinna or external auditory canal, or even eustachian tube, right? So these are the three types, and yes, this one is the elastic cartilage, and these cells what you are seeing actually, these are all chondrocytes, right? So these are chondrocytes. Okay, so if you can see here, these are all chondrocytes, and then there are elastic fibers in the matrix, right? Now, out of the three types, the easiest to identify is the fibrocartilage, right? Out of three, the easiest to identify is fibrocartilage. You can simply see organized cell rows, right? So you can see the cells in a line. So fibrocartilage is easiest to identify, and then elastic is all Hephaestus, but in hyaline we can see a clear looking ground substance, right? So if you look here, neither it's a linear orientation of the cells, neither there is clear background, so we can go for elastic cartilage, right? So out of the three, fibrocartilage is pretty easy, and I'm very sure no one will mark this thing wrong if it comes in the exam. So fibrocartilage, quite easy to identify. And then there is, of course, densely layered collagen fibers. You can see the lines in the image, right? So this is all collagen fibers, and these are all chondrocytes. Clear? So fibrocartilage, then hyaline cartilage and elastic cartilage, right? So this is the elastic cartilage. Anyway, moving forward to next question. Again, whenever there is a case of tumor, always note the age first. The very first thing you have to do is to look at the age, right? Then as we go forward, there is swelling around wrist, and then a photograph and X-ray has been given. So the moment you look at the photograph, even more importantly, if you look at the X-ray, you will jump onto the straightforward diagnosis. So I think everyone can make a straightforward diagnosis in this particular case, and that is very good, KK, very good. So this is the giant cell tumor, right? Yes, this is absolutely right. So you can see swelling here on the ulnar border, so it is related to ulna, right? And in the X-ray you can see there is the expansile swelling. Yes, Pragati, yes, this is. So you can see expansile swelling in the lower end of ulna, right? And again it is originating in the epiphysis, right? So for GCT, I have already told, like, you should remember two E's, right? So one is epiphyseal, and second is eccentric. Clear? So it is more towards one side. So if I show you here, so if we draw a line along the mid-axis of the ulna, you can see that the swelling is more towards one side, right? So it is more towards one side, so therefore we call it eccentric. And of course it is expansile, and many times we see a classical, the soap bubble appearance, although not better visualized in this particular X-ray, right? So many times we see a classical soap bubble appearance also, right? And the histology we have already discussed. So this is soap bubble appearance on X-ray. Clear? So just remember this much for GCT. Chalo, next question. Again, look at the age first, right? Then low back pain and early morning stiffness, and he has now heel pain also. What can be the diagnosis? Low back pain, early morning stiffness. This is actually stiffness of the back. Perfect, perfect. KK, yes, this is a classical case of ankylosing spondylitis, right? And there is early morning stiffness. Yes, Pragati, absolutely right. This is ankylosing spondylitis. There is early morning stiffness, and this goes away with activity, right? So the classical presentation is that whenever the patient will get up from the bed, he will have severe back pain, and then he will say that as I am involved in day-to-day activities, the pain, it disappears, right? So that is a very classical presentation. The moment a young, especially male, tells you like that, straight away you can say most likely your condition is ankylosing spondylitis, and then of course you will go for x-ray. And yes, Pragati, HLA B27 also, right? And here one point is also given, heel pain. Now what is this heel pain? Since it has been mentioned here, so we have to discuss it as well. Now what is this heel pain here? And to discuss heel pain, we can recall one word that is known as enthesitis, right? So what is enthesitis? Pain at the insertion of tendons or attachment of soft tissue. So one classical point is attachment of tendoachilles over calcaneum. So that point is also, yes, KK, absolutely right, that is enthesitis, right? So this heel pain, it can be plantar fasciitis as well, but more importantly in relation to ankylosing spondylitis, you should know enthesitis, right? So any point where there is attachment of soft tissue over the bone, those points becomes extremely painful, and that is what is enthesitis, right? So a classical case of ankylosing spondylitis, right? Chalo, next case, again go with the age. So young male, right? So young male with backache, morning stiffness, and reddening of eyes, and this is the x-ray given. Now what diagnosis you will make? Now I think this is pretty easy here. No one should mark it wrong. Yes, what is this condition? Yes, anyone? Very good, KK, very good. So this is actually the bamboo spine, right? So there are syndesmophytes which actually, so these are syndesmophytes which actually are fusing the two vertebral bodies. Yes, dagger sign, yes, very good. So this is the bamboo spine. Yes, Raman, we can see the dagger sign as well. So this is a classical bamboo spine. So yes, the diagnosis is ankylosing spondylitis, right? So young male, backache, morning stiffness with bamboo spine, ankylosing spondylitis. Now they have given one word here, reddening of eyes. So since they have mentioned it in the question, so we have to discuss it. What is this reddening of eyes? Any idea why this patient is having redness in eyes? Yes, anyone? Very good, KK, very good. So nearly 1/3 of the patient with ankylosing spondylitis, they have acute anterior uveitis, right? So whenever there is some information is given in the question, it has some relevance to the condition which is discussed in that question, right? So you should try to take all the keywords maximum whatever possible, and then you will get a clear picture that what exactly the answer should be, right? So this is a classical case for ankylosing spondylitis. Chalo, next question. Now again start with the age, and the x-ray has been given which is showing white lines. So I think Thank you, Renuka. I'm trying my level best. So, a 6 years old child, X-ray, both the knees has been done, and the X-rays are showing white line. So the moment you find the word white line, I think that's pretty easy that what the diagnosis will be. Any other, anyone who can answer this? See, white lines. And if I show in the X-ray, you can see this is the white line at the metaphysis on both the side, both the lower end of femur. Very good, Pragati, very good. So this is a classical case of scurvy, and these white lines are actually white lines of Frankel, right? So no problem. Sometimes we just mix up. So these are actually white lines of Frankels, right? So these are white line of Frankels. And then apart from that, you can also see Wimberger rim sign. Okay, so you can see the Wimberger ring sign, and then also you can see the Palcon spur. So if you look here, you can see the Palcon spur, right? So this is spur, this is ring, and this is the white line. So these are the three important X-ray features in a case of scurvy. So it's pretty easy. Just make sure that you don't mix up again, right? And for rickets, they will always give you like genu varum, or you can see like if suppose if it is a case of rickets, how you can differentiate. In rickets, if you look at the metaphysis, it will be like this, of course, but the epiphysis will be at a distance, and this all area is actually physis, right? So what we call it widening of physis of growth plate. So that is very important in rickets. And of course for metaphysis, you can say cupping and splaying. Clear? So these are two important points which you should mark in KK. I can understand it's really confusing at times, especially when the clinical symptoms are not given at all, right? Suppose in this case, if they have mentioned you like bleeding gums, then I think you could have 100% you could have marked it right? But if they just mask these diagnostic terms and they leave it all up to X-ray, then in scurvy and rickets, you have to look at the physis, right? So if I just erase everything from here, what you will see, you will firstly mark out the metaphysis, right? So mark out the metaphysis first, number one. Then you should mark out the epiphysis, right? So if you see here, the epiphysis is very close to metaphysis, and it cannot be rickets. In rickets, you see a very big gap between the epiphysis and the metaphysis. So that is one way in which you can differentiate whether it is a case of whether it is a X-ray of rickets or scurvy, right? So the very important finding which will guide you is the width of physis. So just look at the dimension of the physis. If it is normal, no problem. If it is widened, straight away go for rickets. No doubts whatsoever, right? So this is one point which I think will help you always, because metaphysis you might confuse it, because here also you can see the metaphysis is slightly splayed, so that might confuse you, but this physis thing will always help you in reaching up to the perfect answer, right? So I hope that will clear your doubt. And to be perfect in these kind of questions, it's better you look 50 X-rays of scurvy and 50 X-rays of rickets, and after that you will be perfectly fine, I guess, right? So it's just a matter of practice, I would say. Next question. Now a patient after a fall from bike developed pain around hip, and then there was shortening, and the limb was in attitude of flexion, adduction, internal rotation. I think, welcome Kiki. So the moment you have these kind of words, fadir, post-trauma, I think the diagnosis is very straightforward. So there should be no confusion whatsoever in this. Yes, one can straight away jump to the diagnosis of posterior hip dislocation, right? So this has been asked n number of times, and I think this is one of the, in every session, whatever exam, you will definitely find some component related to hip dislocation. Yes, Pragati, absolutely right. This is posterior hip dislocation, right? So please never mark it wrong. Yes, perfect. Now, there was a image-based question, and it was like, which nerve is checked here? So just look at this image and answer me, what nerve is being checked here? I think it's pretty easy, because if you look at the pen, you can say this is a pen test. Yes, so this is pen test, right? And pen test is done to rule out injury of or paralysis of median nerve. Very good. Now, can anyone tell me which muscle is checked here? Which muscle is checked? So if I write muscle tested, which muscle is tested? Anyone? Which muscle is tested here? See, we are checking some movement of the thumb, so one word has to be pollicis, right? So one word has to be pollicis. Now, which movement we are checking? The moment you can appreciate the movement, you can answer little bit more closely. So we are checking actually abduction, right? So this is abduction, right? So we are checking abduction. So we are checking abductor pollicis, and the third thing which you have to remember is very important. So please remember, it is brevis. Pragati, this is abductor pollicis brevis. Okay. So this is abductor pollicis brevis. No problem. That what is actually the confusion in this question, because many times students, they go for abductor pollicis longus, but this is actually abductor pollicis brevis, right? So this is abductor pollicis brevis. No problem. Just make sure that you don't mix up now onwards. That's very important, right? So we should learn our from our mistakes. That's very important. And I think pointing index, everyone must be knowing the pointing index, which is one more classical clinical sign of median of palsy. So if you tell the patient to make a fist, the index finger remains straightened or extended, and that is the classical index finger, right? That is the pointing index. Chalo. Next question. A patient has road traffic accident, and following that he have multiple humeral injuries or fractures, and then he developed loss of sensations over the lateral aspect of forearm, and then he is also having difficulty in flexion of elbow and supination of elbow. Now, which nerve is paralyzed here? Now, this is a very good question and not so commonly repeated. So one thing which you can see here, there are two components, motor loss, and the second component is sensory loss, right? So what we can see in motor loss of flexion at elbow and loss of supination. And in terms of sensory loss, there is loss over the lateral aspect of forearm. Yes, very good, very good, very good, KK. So this nerve is musculocutaneous nerve, right? So this is the musculocutaneous nerve. So it has got a motor component, it has got a sensory component, and sensory is lateral aspect of forearm, and motor, it supplies actually three muscles, and you can remember it like BBC. So B is for biceps brachii, fine. Second B is for brachialis, and third B is coracobrachialis, right? So this is coracobrachialis, fine. Now here there is loss of flexion at elbow and supination, so that is attributed to biceps muscles paralysis, which is consequent to injury to musculocutaneous nerve, right? So there is musculocutaneous nerve injury, and the motor part is attributed to the biceps brachii paralysis, and I think sensory is quite evident that this is the area of musculocutaneous nerve sensory loss, right? So this is sensory loss over the lateral aspect of, you can see this is the thumb, so this is the lateral aspect of forearm, right? And that flexion is gone because biceps is gone, which also supports in supination, right? So this is musculocutaneous nerve. Very good question. Chalo. Then there was a lady who went for antenatal ultrasound, and and on ultrasonography it was found that the fetus is having fractures in multiple long bones. Now what can be the condition with which the fetus might be suffering? So multiple fractures in long bones, straight away you can go to the diagnosis of, yes, anyone? Multiple fractures in long bones. This is very good, KK. So this is osteogenesis imperfecta. In children's, we have to differentiate it by from battered baby syndrome, in which there is a history of assault to the child, but antenatal, straight away you can jump to osteogenesis imperfecta. Yes, KK, Pragati, absolutely right. Now next question, a patient has multiple swellings in the hand, right, and the x-ray is given. Now what can be the diagnosis? Look at the x-ray and you can see the answer is very easy here. You can see expansile lytic lesions, right? What can be this? Involving so many bones. Metacarpals, phalanges. Yes, it can be multiple. Not cake. See, I tell you one thing. Whenever you have a case with hand swellings, right, in terms of orthopedics, an X-ray showing multiple lytic lesions, okay, and sometimes you can also use the word add the word expansile, straight away you have to jump to the diagnosis of enchondroma, right? So straight away, the moment you have any expansile lytic lesions involving the metacarpals or the phalanges, enchondroma, right? And then it can be like it can be, yes, KK, it's enchondroma. It can be at one place or it can be at many places. So this is classical enchondroma. So hand x-rays, expansile lytic swellings, please go for enchondroma, right? So this is enchondroma. Now next question, you can see a procedure which has been done, and what you can say about this image? What you can say, right? In orthopedics, we do fixation, right? And fixation, we have two categories. Either we can do internal fixation, right? Or we can do external fixation. Clear? So this is not actually Ilizarov. Ilizarov is ring assembly, right? So anyway, no problem, and we'll take the concept as such, because I'm very sure such kind of question will not be repeated again. So this is not a very favorite topic, but yes, we should understand the concept of fixation in orthopedics. So whenever there is fracture, it has to be fixed. So we have two modalities. Either we can go for internal fixation, or we can go for external fixation. Now, as the name suggests, internal fixation. So what we do, we have to do surgery, and then we do open reduction, right? And then we fix it internally with, plate, screws, or whatever implant, right? So this is open reduction, internal fixation. Now there is another method of fixation in which we don't give any incision, we don't do any surgery. We do a percutaneous fixation. So percutaneous pins are passed in the bone, right? And then it is, and then assembly is made to stabilize the fracture area, right? So this is external fixator. Now, what is that point which actually guide us when we should go for internal fixation and when we should go for external fixation? That is importantly in terms of clinical practice, that is open fractures, right? Most importantly, because if there is any wound, and I think most of you must be knowing what actually open fracture is, or you can also say it is compound fracture or wound with fractures, right? So whenever there is a wound in the vicinity of the fracture, never do any internal fixation, because if you do any internal fixation, you can land up in infection, right? So that is very problematic to manage. So therefore we never advise to go for internal fixation in case of open fractures. Always go for external fixation, let the wound heal. Once it heals, then you can go for any fixation or whatever you feel right at that moment of time, right? So this is the concept of external fixation. Now in this particular case, it is an assembly of external fixator, right? So what you can see one pin is here, another pin is here. So these two pins are in tibia, right? Then you can see one pin over here, another pin over here. These pins are in femur, right? And then we are using connecting rods, right? So these are the connecting rods. And then we are using the clamps also, so as to fix the rods to the pins, right? So this is the assembly of external fixation. Now in this case, the injury is somewhere around the knee joint, right? So this is the area of injury, and you can see there is so much of swelling. So such injuries which are nearer to the joint are known as periarticular injuries or fractures. Peri means surrounding, articular is joint, right? So these are actually periarticular fractures. So this is a classical case of spanning fixator. Now this is known as spanning fixator because it is spanning across the knee joint. It is not holding any structure of the knee joint. The assembly which is in the bone is distal to the knee joint, and the proximal assembly is the pins in the femur. So we are spanning across the knee joint, so it is known as a sort of spanning external fixator, right? So this is for injuries around the knee joint which are not very easy to fix. So if you can see here, there is so much of comminution here in the proximal tibia, and that is very difficult to fix. So what we can do, we can put a spanning fixator, 2 pins in the tibia, 2 pins in the femur, and then we will put the assembly of external fixator, right? So this is joint spanning external fixator, right? So for external fixation, the clinically most important indication is open fracture, compound fractures, or fractures with wound, the same thing, right? And this, in this particular case, it is periarticular fracture, not open fracture. But from exam point of view, you should remember about open fractures. Now, coming to that word illusorofixator, as mentioned by KK, so I think it's very important to just have a basic idea. Suppose this is tibia. So what we do in illusorofixator, we pass pins like something like this, right? So the pins will go something like this, and then these pins are connected to the rings, right? So these are illusorov rings, and then the rings are connected to each other by rods. Okay, so this is the assembly of illusorofixator, and this is also known as the illusorov ring fixator, right? So it's very easy to identify. There is metallic rings which are surrounding the limb, right? So illusorov is quite easy to identify. Anyway, this is a external fixator, and illusorov is also a kind of external fixator, right? So this is the concept of fixation. Now, moving forward to next question, there is an injury which is shown in the X-ray, and it was asked like what you will do. So firstly you have to locate the fractures, okay, and then the second fracture you can see somewhere here like this, okay. So this is which type of injury? This is the lateral malleolus, and this is the medial malleolus, right? So if both the malleolus are fractured, we call is bimalleolar fracture, also known as Pott's fracture, right? So bimalleolar because there is fracture of both the medial malleolus as well as the lateral malleolus, and for this particular case we do open reduction internal fixation, provided it is not open, right? So, and whenever we say fracture, we presume it to be a closed fracture, right? So we do ORIF, and what actually we can do, we can pass a malleolar screw, something like this, okay. So here we can pass a malleolar screw, and for lateral malleolus, we can apply a plate, and this can be fixed with screws, right? Something like this, okay. Okay. So this is how we fix the bimalleolar fracture. So we need to do ORIF. So you can see this is malleolar screw, and this is the plate plus screws. Clear? So this is pre-operative. You can see that this is the medial malleolus fracture, and you can see there is fracture of the lateral malleolus also, usually a spiral variety, right? So this is ORIF, open reduction internal fixation. So for this particular injury, we need to do ORIF. Chalo, next question. Now, what can be the set of complications in this particular condition if it is not managed properly? Now, firstly, you have to identify what injury is this, right? Right. So what injury is this? Now this is radius, this is ulna, and you can say that this is a case of fracture lateral humeral condyle, right? So this is lateral humeral condyle. Now what complications can come if you don't do or if, right? So it has to be managed by or if. But in case if you don't do or if, then this will go into non-union. Clear? So it will go into a state of non-union, and what will happen? There is cubitus valgus deformity which can cause tardy ulnar nerve palsy. Fine. So this is, yes, KK, you are absolutely right. And why it will go into non-union? Because you see, this is one end, right? And this is the other end of the fracture. Now there is so much of gap. A bone cannot unite with so much of gap. So what we do? Therefore we always say do open reduction internal fixation. Because until and unless you approximate both these fragments, they are not going to unite. So therefore the complication will be non-union. And what will happen? The medial, this is medial epicondyle, right? So the medial side will continue to grow and patient will develop cubitus valgus, and over a period of time, since there is ulnar nerve which is passing behind the medial epicondyle, it will be stretched, and that would lead to paralysis of ulnar nerve, and therefore we use the word tardy ulnar nerve palsy. So tardy means slow, and that is slow to come because of that stretching which occurs for some period of time before finally resulting in tractional injury to the ulnar nerve. So it is known as tardy ulnar nerve palsy, right? Tardy means slow, or you can say lazy, right? So this is not at the time of injury. It will take some time when there is non-union, which leads to cubitus valgus deformity, finally putting traction over the ulnar nerve behind the medial epicondyle, right? So this is lateral humeral condyle, and therefore we always say please manage it by open reduction internal fixation if it is displaced. Undisplaced you can manage conservatively, but for displaced there is no role of conservative management. Chalo, next question. Now here a patient has pain in forearm and leg. X-ray shows diaphyseal sclerosis, and then the peripheral smear of the patient was given. Now which organism can cause this kind of presentation? So this was actually a pathology and orthopedics integrated question. So if you look at the peripheral blood smear, you can clearly see what you are seeing in what you can see in the peripheral blood smear here. Any idea? What you can see in the peripheral blood smear? Very good, KK, your answer is absolutely perfect. So we are seeing actually sickle cells, right? So what we are seeing actually the sickle cells, right? So sickle shaped RBCs, very good. So again, this is sickle cell, this is sickle cell, right? So we can see a lot of sickle cells, and in case, now in sickle cell anemia, now this osteomyelitis is caused by, of course, we have discussed it previously also, this is caused by Salmonella typhi. Otherwise in general population it is caused by Staphylococcus aureus, but here specifically in a case of sickle cell anemia it is Salmonella typhi. And in case history you are getting this word, pain in forearm and leg. So this can be vaso-occlusive crisis, which are seen when there is sickling, and those sickle cells, they go and they block the small vessels, right? So this can be that vaso-occlusive crisis. And then classical X-ray finding is diaphyseal sclerosis in sickle cell or salmonella osteomyelitis, right? So this is salmonella osteomyelitis, especially seen in sickle cell anemia. So quite easy to answer, provided you understand the clue given in the peripheral blood picture, right? Chalo, next question. A patient of road traffic accident having multiple injuries, then after 2 days he developed tachypnea, petechial rash and became drowsy. So I think it is quite straightforward question. You are getting multiple injuries, right? 48 hours, then respiratory symptom, increased respiratory rate, that is tachypnea, then there is classical rash and CNS symptoms. So the moment you have these much of clues, I think there is no point in making a wrong diagnosis. So the answer is fat embolism, right? So very easy. Now, which vitamin deficiency you can correlate with this given X-ray? Now, I think this time no one should make any mistake in this X-ray. This is a classical X-ray of deficiency of which vitamin? Anyone? Yes, I am waiting for your answer. Anyone? This X-ray suggests deficiency of which vitamin? Vrinder Pratap, absolutely right, gentlemen, absolutely right. This is vitamin C. And yes, now again, what you can see here, you can see white line of Frankel, right? So you can see number one, white line of Frankel. So this is white line. Then you can see spurs, which are Palkan spurs, right? So these are two important points. Yes, KK, vitamin C. So I think here you can, again, firstly you can just look at the margins of epiphysis and the extent of metaphysis, right? So there is no widening of physis as such, and therefore you have to exclude rickets. Then, so firstly you will look at physis, right? So the first thing is look at the physis, and if there is widening, straight away go to rickets, right? If it is normal, then look for white line or Palkan spur, and then you can say it is a case of scurvy, right? So this is again a classical case of X-ray scurvy. And here can you also see Trummerfeld zones, actually, which are zones of osteopenia surrounding that white line of Frankel in the metaphysis, right? So you can see three things here: Trummerfeld zones. So this is the Trummerfeld zone, this is Palkan spur, and this is Frankel's white line, right? So these three keywords are actually just to help you in getting the answer, right? So you can see the Palkan spur, something like this. Okay, anyway, so just this should be the approach when you want to differentiate rickets from scurvy, right? Chalo, next question. A patient has chronic knee pain, and then when you get the X-ray done, this was the finding. Any idea what is this? Now again, this is rarely asked topic. So this is AP view and this is skyline view. right? So a skyline view, what we do, we flex the knee to 90 degree and then we take a axial view, right? So here you can see these are the femoral condyles, right? So these are the femoral condyles, and this is of course the patella, and here this is the outline of patella. So you can see something like this. Similarly, if you look here, you can see something like this. Very good, Pragati. This is bipartite patella. Yes. So this is bipartite patella, and this is a incidental finding, like, right? So this is an incidental finding. Sometimes you are doing X-ray for some other condition and then you realize that okay, this is also there. So this is bipartite patella, and this can be bilateral in 50% of cases, right? So if you see bipartite patella on one side, get X-ray of other knee as well, right? So this is bipartite patella. Okay, so it's an incidental finding. See, why it won't be a fracture patella? Because there is no history of trauma, right? So there is no history of trauma, or there is no history of any vigorous pull by the quadriceps muscle. So this is bipartite patella, right? So this is just an accidental finding. Chalo, next question is very important and it has been asked over the years. Fracture at which site will lead to loss of dorsiflexion of foot? I think everyone should mark it right, because this is one very common question which has been repeated over the years. Now, which area, if fractured, it can injure some nerve, and that nerve is wonderful, KK, wonderful. So actually, loss of dorsiflexion, right? Now, which muscles are responsible for dorsiflexion? So dorsiflexors are mainly, which muscles are dorsiflexors? Any idea? Yes, nerve is okay, common peroneal nerve. But which muscles are dorsiflexors of foot? Any idea? Yes, clinical condition is foot drop. Absolutely, I totally agree with you. But which muscles? Let us go in little bit of anatomy. Pragati, yes, common peroneal nerve is the right answer. But just some relevant anatomy, you can say. So let us discuss the relevant anatomy here. What are the dorsiflexors of foot? Which muscles are dorsiflexors of foot? Any idea? Especially of the anterior compartment of leg. I just want to hear two names at least. So one is tibialis anterior. Okay, one is tibialis anterior and second is extensor digitorum longus, and also supported by, especially for toes, it is extensor hallucis longus, and there might be some contribution from peroneus tertius as well if it is present, right? So but please remember these two muscles, tibialis anterior and extensor digitorum longus. Now these two muscles are supplied by which nerve? What is the nerve supply of these two muscles? Any idea? What is the nerve supply of tibialis anterior or extensor digitorum longus? It is deep peroneal nerve, right? And deep peroneal nerve is a branch of common peroneal nerve, right? Because the other branch of common peroneal nerve is superficial peroneal nerve, which supplies the peroneus longus and peroneus brevis, which are actually the everters of foot, right? So this is the relevant anatomy here. Now what happens? The common peroneal nerve, it winds round the neck of fibula, something like this, right? And then it divides into the two branches. Okay, so this is the common peroneal nerve, this is the deep peroneal nerve, and this is the superficial peroneal nerve. So whenever there is a fracture somewhere here, suppose somewhere here, this is fracture neck of fibula. Clear? So whenever there is fracture neck of fibula, there is high possibility of involvement of common peroneal nerve, which, although it will involve both, but clinically it's very easy for us to check for dorsiflexion. So what we'll do, we'll tell the patient to dorsiflexion. So this is normal and this is the foot drop. Clear? So foot drop, it can be paralysis of deep peroneal nerve, or most importantly it is common peroneal nerve, which is related to the neck of fibula, right? So therefore whenever you see a case of fracture neck of fibula, always check for dorsiflexion whether it is present or not. If it is absent, you can straight away tell the patient, see, your common peroneal nerve is gone. Otherwise, if you don't document it at that time, later on they will blame you for that nerve palsy, right? So it's very important from clinical point of view as well. Now what is being, next question, what is being shown in this image? What procedure is this? Especially in cases of infants or cases of burn patients, we do, what is this? Yes, anyone? Intraosseous cannulation. Now intra means inside, osseous is of course bone. So what we do, we pass, yes KK, it's intraosseous, so we pass a needle, a white bore needle in the metaphysis, and then we can give IV fluids also. So this is intraosseous cannulation. It can be given for infants, or sometimes we can try it on burn patients if we don't find the veins, right? So this is intraosseous cannulation, and it is just for you to identify, no need to go for details. Now what you can look in this X-ray, any idea? This is head of femur, this is neck, this is greater trochanter, and then you can see the shaft, something like this. Yes, what is this? Classical X-ray. I think the moment you look at this arrangement of femur, you can say, yes, it is nothing except Shepherd's crook deformity. Very good. So this is the classical Shepherd's crook deformity, and the moment of proximal femur, yes, of course, of the proximal femur. And this is classical for which condition? Virender, you are absolutely right. But what condition is this? The moment you see this Shepherd crook deformity, what condition you should think of? This is fibrous dysplasia, right? Yes, very good, Virender. So fibrous dysplasia. So it means there is some fibrous tissue within the bone. So that is fibrous dysplasia. Okay. Chalo, next question is about X-ray of a wrist in a female of 25 years. So again you can see the X-ray, young lady, what you will say. The moment you see the X-ray, I think it's quite obvious about the diagnosis. So you can see multiple septations, right? Lower end of radius, classically, yes, this is classical soap bubble appearance. Okay, so this is classical soap bubble appearance, distal end, radius. The diagnosis is straightforward: giant cell tumor or osteoclastoma. Clear? Although the most common location for GCT is, any idea what is the most common location? Most common location is knee joint, around the knee joint, right? So lower end femur, upper end tibia. Clear? So these are the usual common locations of GCT, but majority of the time we have seen questions in the exam mentioning the findings of radius, right? So that is one more important thing. Chalo, next question. 45 years old male having low back pain, stiffness, and ESR, C-reactive proteins are raised. Then mild restriction of chest movement and chest expansion is only 3 centimeter. There is history of red eyes. I think this is sufficient enough to make a diagnosis of. So what can be the diagnosis here? Back pain, stiffness, my dearest Dr. A, I will try my level best as a human. I'll try, right? Don't worry. Medicine, psychiatry, anesthesia, forensic, anatomy. Okay, I'll try my level best. Right. So yes, KK is classical ankylosing spondylitis, right? So I think back pain, stiffness, that is very straightforward terms. And Dr. A, I'll be very happy if I can know your full name, because it does not take me anywhere. Yes, Pragati, ankylosing spondylitis, right. Virendra Pratap, absolutely right. So back pain, stiffness, that is one, that are few points which lead you towards ankylosing spondylitis, right? Now there are two more important things here. Mild restriction of chest movements and chest expansion is less than 3 centimeter. Is 3 centimeter. Red eye is of course acute anterior uveitis, that I think everyone knows, right? So this is acute anterior uveitis. Now I am more interested in discussing these 2 points. Restriction of chest movements, and the second point which is written here is chest expansion 3 centimeters. Now since okay Tanu, thank you so much, thank you very much. Now since there are these 2 points in the question statement, so I think we should just discuss them as well. Now the point is restriction of chest movements and chest expansion is 3 centimeter. Now whenever a value has been given to you, you have to appreciate whether that value is normal or less or high. Now here a normal expansion should be around 7 centimeters, right? So if you know that normal value, you can say that the chest expansion is reduced, and the chest and that can be correlated to the reduced chest movement. So it means when you tell the patient to inhale maximally, chest expansion won't be too much, and that what suggests that there is the process of ankylosis is going on, and that is also affecting the expansion of the thoracic cage. So this all is attributed to the ankylosing process, right? So this is because of that ankylosing process, which is the hallmark of ankylosing spondylitis, right? So these words are just supportive to your diagnosis of ankylosing spondylitis, right? So few words we have already discussed, but these were 2 new points which were mentioned here. So just take on your side that these are 2 also important clues to reach up to a diagnosis of ankylosing spondylitis. Now I think everyone can identify what splint is this. Any idea? What splint is this? Any idea what splint is this? Very good, very good. Now here, cock-up splint. Now in older times, what we used to do, we used to apply the static cock-up splint. Now in static, what we'll do, we'll simply give a splint and we'll keep the wrist in, you can say somewhat around 20 degree of dorsiflexion, right? Because what happens in, I think cock-up, everyone must be knowing that this is for radial nerve palsy, right? So this is radial nerve palsy. So what happens, this is radial nerve palsy and the wrist is in palmar flexion, you can say. So we try to keep it to a neutral position, that is around 20 degrees of dorsiflexion. Now whenever you are giving static kind of splint, what is happening, the flexors which are normal, they are also immobilized, and that could lead to wasting, or you can say disuse atrophy. They are normal, but we are not allowing the patient to use them because a splint is there. So that would lead to atrophy of the flexor muscles. So that had led to the concept of, now this leads to disuse atrophy of flexors which are normal actually. So this has led to the concept that this static should be replaced by dynamic. So it has to be replaced by dynamic. Now in dynamic, what happens, we can see a spring system here, you can see a spring system. So the patient is free to palmar flex. This is active. So he can palmar flex, but because of this spring system, there is passive dorsiflexion. Clear? So whatever the attitude we are achieving by static, it will come by the use of this spring system, and patient can use the flexors also actively. So this side effect was avoided, right? So therefore nowadays the concept is use dynamic splints, because static splints, one group of the muscle is already paralyzed. Now if you don't mobilize the other group of muscles, they will also atrophied, right? So in terms of wrist, we have two muscles, extensors, flexors. So extensors are already gone, so let us keep the flexors working. Why to atrophy them unnecessarily? So this is the reason, or this is the logic behind the promotion of these dynamic splints. Okay, in older times we always used to give static, but nowadays we prefer dynamic. Chalo, next question. A patient had some problem at the night, and what actually he feels that there is tingling sensation and numbness sensation that involves lateral 3 digits, and he explains that these symptoms are relieved when he hangs the limb from the bed. Now the moment you have this kind of words, I think everyone can mark it. So lateral, actually 3.5 digits to be more specific, volar side paresthesia, or what you call sensory disturbances. The answer has to be, it has to be compression neuropathy of which nerve? Yes, anyone? Very classical case. Which nerve? Compression neuropathy of lateral 3.5 of the volar side, or you can say palmar side. Same thing. Yes, which nerve is compressed? Virender, I don't agree with you in this. See, this is median nerve, and this is a classical case of carpal tunnel syndrome, right? So this is carpal tunnel syndrome. See, 3.5 lateral median, 1.5 medial is ulnar, right? So okay, this image will help you in remembering the concept. So this is thumb, this is taken as first, index is taken as second, then middle is taken as third, and then ring half, right? So this is lateral 3.5, Okay, on volar side. This is very important. Not on the dorsum, only on the volar side, right? So volar side 3.5 is all territory of median nerve, okay? And whenever you see a case who is complaining of tingling, pricks, burning sensation, numbness, think of compression of the median nerve as it passes through the carpal tunnel syndrome. So this is the median nerve as it passes through the carpal tunnel, which is actually a osteofibrotic canal, right? So it has high chances of compression over there, right? So this is a classical case of carpal tunnel syndrome. So the keyword which you should remember from this question is lateral 3.5, volar side, sensory disturbances. You have to answer median nerve. Now if this would have been medial 1.5, this is little finger, it is fifth, and then half of the ring finger, right? So this 1.5 is all territory of, this is all ulnar nerve. Clear? So please remember this picture, and this is one very important. No problem, Virender. Right now you have all authority to do all those kind of mistakes, but my request is just make sure that you don't, repeat the same mistake again. That is very important. So this is all the purpose of conducting all these sessions, na? Anyway, that's not an issue, and as a human, we all, sometimes as a teacher, we can also do mistakes. So that's, no one is immune to committing those mistakes, but a wise person will make sure that he don't repeat the same mistake again, right? So this is carpal tunnel syndrome, a very important concept, and there are two clinical tests what we do. One is the Phelan test, right? So this is the Phelan test, and here we are actually flexing the wrist, and if somewhat for about 1 minute or so, this will increase the compression over the median nerve, and the symptoms of the patient will aggravate, right? So this is the Phelan test. Clear? So we are just trying to aggravate the compression of the median nerve so as to increase the symptoms. And another is Durkin test, where we are pressing upon the median nerve for around 30 seconds, and again this is a sort of compression that will provoke the symptoms of compression of the median nerve, right? So these are two tests. One is Phelan test and another is Durkin test. Then there is one more Tinel sign, which can be like stroking the median nerve, and we can see the symptoms, right? So there are three tests related to medial nerve compression, and this is a classical carpal tunnel syndrome, right? So I think you must have enjoyed the session, and yes, I would request everyone to please stay connected on Telegram at least, because all notifications I'll put here, right? So sometimes the class might be delayed or whatever because of some technical reasons, right? So I'll request everyone to be with me on the Telegram group, and that would make my work a little easier, right? So with these words, I would like to say thank to all of you for just sparing your valuable time with me and attending this academic session. So okay. I think you can scan this QR code, or you can just search Dr. Kamal KV group, right? So this, I think if you can search this, you will get up to me, and then I'll give you the link on Telegram, right? So this is all from my side for this session, and tomorrow we have a anatomy session for FMG, and yes, I'll try to plan some more NEET-PG PYQ session that I'll update on the Telegram group, right? So with these words, I will seek your permission. Thank you everyone. Good night. Stay blessed. Work hard. God bless you.